I just want to welcome everyone and introduce myself. I'm new to MDC and my name is Alia Kareem and I am with the research and advocacy team here at Muscular Dystrophy Canada. So I'd like to welcome you to our webinar, as Dr. Bril said, on myasthenia gravis. So this is part of our Let's Talk NMD webinar series in recognition of Myasthenia Gravis Awareness Month in June. And we're happy to offer today's webinar in both official languages. So you can use the globe icon at the bottom that says interpretation to access the language of your choice. So you can select English or French. I'm just going to turn it over to Marie-Hélène, who will give you the instructions in French.
Oui, merci Elia. Alors, bonjour, bienvenue à tout le monde pour cette conférence sur les mises à jour sur la myasthénie grave. C'est le mois de la myasthénie grave au mois de juin, donc on est vraiment très heureux de présenter cette conférence-là avec deux incroyables conférencières. Je voudrais vous informer tout d'abord que c'est une conférence qui est bilingue. Si vous regardez à droite dans le bas de votre écran, vous avez une icône en forme de globe terrestre qui s'appelle Interprétation. Si vous voulez écouter la présentation en français, vous n'avez qu'à sélectionner French et vous allez entendre la présentation en français. Alors, bonne conférence tout le monde. Merci.
Merci, Marie-Hélène. Great. So as I said, we're very excited to have here today Dr. Vera Bril and Dr. Carolina Barnett-Tapia. And I'll briefly go through Dr. Bril's bio, even though she gave us a really great overview. But she is a professor of medicine at the University of Toronto. She's also the director of Neuromuscular Section at the University of Toronto and the University Health Network. She did go over all of her other research endeavors, and I just wanted to mention that her research interests have centered on the diagnosis and evidence-based treatment of myasthenia gravis, inflammatory polyneuropathies, and diabetic sensory-motor polyneuropathy, leading to publication of more than 330 journal articles. I'd also like to introduce Dr. Barnett-Tapia, who's also obtained her medical degree, but in Chile. And she completed her neuromuscular fellowship at the University Health Network in Toronto, which she combined with a PhD in clinical epidemiology and healthcare research at the University of Toronto. She's an assistant professor in the Department of Medicine and the Institute of Health Policy, Management, and Evaluation at the University of Toronto. Her main research interests are patient-centered outcomes and patient preferences in treatments in patients with neuromuscular disorders, especially in myasthenia gravis. And she's actually also received funding from MDC for her work on patient preferences in treatments for MG. If you would like to take a look at our past webinars on myasthenia gravis, I can just put the link in for last year's talk. I'll just put it in the chat. And we will be monitoring the Q&As, so feel free to add any questions you have along the way, and there'll be time for some questions at the end. So I will hand it over to you, Dr. Bril. Thank you so much for getting us going.
Good day to everybody. Today, this is a webinar on myasthenia gravis, and we're starting on an update on the treatment of myasthenia. I'll start. My name is Vera Bril. I'm a professor of neurology from the Ellen and Martin Prossman Center for Neuromuscular Diseases at the University Health Network, University of Toronto. My disclosures are shown on this next slide. I'm a consultant for multiple industry partners and also have received research support from a number of them. So I'm going to start with a very brief background on myasthenia. It's a rare disease, considered rare, and it's chronic. It's something that you don't cure, you manage. It is variable, meaning heterogeneous, clinically can vary very much in what kind of symptoms you have and how severe it is and how much it impacts patients' lives. Myasthenia, the acquired form, which is the most common, is due to production of abnormal antibodies against the connection, the neuromuscular junction, where the nerve connects to the muscle. And the antibodies are mostly against one receptor, the acetylcholine receptor, but there are a subset of those who have antibodies against muscle-specific tyrosine kinase, and other antibodies have been described that are quite a lot rarer. We have 26 per 100,000 people with myasthenia, but the prevalence is increasing over the years, and that is because people are surviving longer with modern treatment and management. But the number of new cases is 2.3 per 100,000 per year, and that has not changed very much. There are peak onsets in younger women and older men. Ari Briner reviewed this experience in Ontario and published it in 2016. And our numbers are similar to the numbers across the world, very similar with a number per million, as you see, some places a little more and some a little less, and this is probably related to ascertainment. So this is a nerve cell here. This is a nerve cell ending that comes to a muscle fiber here, and the muscle fiber is all crenellated like this, and these are acetylcholine receptors. The nerve releases acetylcholine, which goes across the synapse and reacts with the acetylcholine receptor to form activity that leads to contraction of this muscle fiber and our normal strength. MuSK helps form the neuromuscular junction and assemble these acetylcholine receptors as they are here on the tip, and LRP and LRP MuSK bind agrin and promotes clustering. So we're discovering more and more about the normal structure and function as time goes on. So the primary antibody is the anti-acetylcholine receptor antibody, and the antibody interferes with how the nerve communicates with muscle in three ways. It just blocks off the receptors. So this is the antibody coming in here and it's blocking the receptor so it cannot respond to the acetylcholine. The antibody can also cross-link the receptors, and this abnormal structure then is internalized and broken down within the muscle fiber cell. Or antibody can activate complement, which is part of our immune system, and leads to deposition of membrane attack complex with the complement and interacting with the antibody and the receptor, and it leads to this simplification of the muscle fiber membrane and the dispersal and loss of acetylcholine receptors. So there are three ways that we know that the antibody can work. And the places where we can attack this abnormal activity is in the space, the synapse between the nerve and the muscle, where we can give drugs that slow down the recycling of acetylcholine, because this is a very compact, nice system where acetylcholine is taken back up and it's recycled. And this is by acetylcholinesterase. And if you block that, then the acetylcholine stays there longer and has more chance to react. We also have our chronic therapies, prednisone and other immunosuppressants that are broad spectrum, and they act here on the T cells and the B cells, primary components of our immune system. And we can take out the thymus, which is where our T cells learn how to be abnormal, and we can give IVIG or plasmapheresis that have multiple actions across the immune system. We can give specific drugs that knock down the B cell, such as rituximab, and we're getting to more specific therapies as we go on. Now, what do we want to do? This was updated in the International Consensus Guidelines, but this is really what we want. We want patients to have minimal manifestations or better, meaning no symptoms or functional limitations. They may have a little weakness on exam. Remission is no sign of symptoms, no sign or symptoms, although they may have a little weakness of eye closure, and up to grade 1 treatment-related adverse effects, meaning that with all our treatments, there are only mild symptoms related to the treatment. This combination is what we want to have. And I will leave it to Dr. Barnett to let us know how well we're doing in this way and why we have had to advance in our understanding of our patients and how we should treat them. So the treatment depends on the classification, the antibody status, and the age. Basically, there are congenital forms that don't respond to the immune therapies, and we treat them with symptomatic medication, and that's the acetylcholinesterase to prolong that activity. If there's generalized disease or a tumor in the thymus, then we would resect it. We might modulate the system with broad spectrum IVIG immunoglobulins or plasma exchange or subcutaneous immunoglobulin, and this would be for crises or before surgery or those who are not responding to the other treatments. And then we give specific medications. Now, the current treatments are shown here just to show you our spectrum. We have the immunomodulation treatments here at the bottom 3, but then we have all of these. Steroids, corticosteroids, work in maybe 2 weeks, but really up to 12 weeks you have to try it before you're sure it's not going to work. But then all of these other agents, they may work early, but they really tend to need about a year before you can be sure they're not working. And usually we try not to do multiple drugs at the beginning because if you do multiple drugs, you'll just add to the side effect burden. But this is all very nonspecific. It's broad immune suppression or broad immune modulation. We did look at subcutaneous immunoglobulin in myasthenia. This was a research project led by Dr. Alcantara, a fellow from Brazil, and we found that sub-Q and IVIG were both good, so that was a bit of an advance, so people didn't have to come to a unit every 4 weeks to have IV therapy. And this was just showing pre-scores and post-scores in various measures, which you may hear more about from Dr. Barnett, but showing that patients improved and the improvement was maintained if they went from IVIG to sub-QIG. And then rituximab, it's been around for quite a while. It's a B cell attacker, if you want. It depletes B cells. The trouble is, as we learn more about myasthenia, we learn that different cells and different elements of the immune system play a larger or lesser role in various types of myasthenia. So the MuSK myasthenia, there was a very good response rate to rituximab. This particular antibody, 58% got to minimum manifestations, meaning almost no clinical bother with myasthenia. A study in acetylcholine positive patients did not show benefit in steroid sparing or various other measures. There are other studies that are retrospective and not so strong as this top study, not powered enough, that tended to suggest people improve. And we know maybe a third of patients might improve to rituximab, but it can be very difficult to get. So B cells may play more of a role in some people than others. However, there was a study, an interesting study out of Sweden not long ago by Browner, and they said that if you start treating patients, younger patients with generalized myasthenia who were recently diagnosed, that they got to a shorter time to remission, so that this was the higher the number here, the curve, the better the outcome, and they were showing a good response to rituximab. I must say that it was an open label study, it was looking backwards. It's not the strongest evidence, And there needs to be a better trial to verify this kind of data, and it's not accepted widely yet. Refractory MG was shown here. Now, other than that, rituximab has multiple side effects, which are not often mentioned, but infusion reactions occur with rituximab, and of course with IVIG, they can occur as well. Any infusion can cause infusion reactions, but there are other things like headaches. Whenever you interfere with the immune system, you seem to get more headaches. The possibility of infections being exacerbated as you suppress the immune system, because of course that system fights off infections as well. So you have the risk of more infections. You have the risk around giving vaccinations. If you give a vaccine, but you've suppressed the system that must respond to it, what'll happen? And the same with cancers. There's the risk that you suppress the cells that detect cancer. There is a death rate associated with rituximab therapy, and then there's various neurological things that are not very good that are associated with rituximab. They're rare, but they can happen. So what about the new treatments? And this is why myasthenia is so exciting now. I'm going to show you data, but I won't dwell on it. But you can see all of these drugs that are very recent. Eculizumab has been approved for acetylcholine positive generalized MG, both in Europe and Canada, the US, Japan. Efgartigimod has been approved by the FDA just last December. The application has gone into Health Canada, is into the EMA. It's an FC receptor inhibitor. Eculizumab is a complement inhibitor. And then you have another complement inhibitor in trials, another one here, and then rozanolixizumab, another FC receptor inhibitor, finished phase 3 positive results, and they are now going to be submitting for approval. The others are still in trials. So here, remember I mentioned to you complement led to damage at the neuromuscular junction because of deposition of membrane attack complex and that flattening of the muscle membrane. Here, if you block off this cleavage of C5 by a complement inhibitor, what happens is you block off this pathway into deposition of complement at the neuromuscular junction. And this was the study. This was the regain study, the placebo and the eculizumab, and this was change in one of the measures of myasthenia, the activities of daily living. It improved in both groups because you always have a placebo effect, but it improved much more in those on treatment. And then in the open label extension, you saw that that improvement was maintained, and those who had switched from placebo to eculizumab also were improved. So this led to the ability to get this approved. This just shows if you go and you increase the amount of improvement you need to get from, or with time, sorry, as you go with time, you get more and more people responding. And these patients improved with placebo, but more improved with eculizumab, and then in the open label you had more improving, and the minimal manifestation status also increased with time. The drug was well tolerated. There's a risk of meningitis with complement inhibitors, and so the patients had to be vaccinated against that, and they were, and basically there were no safety signals in with the complement inhibitor. Ravulizumab is another complement inhibitor, but it is a subcutaneous dose rather, oh no, it's an IV, sorry, and it is ongoing experiment, so we don't know how it will be, but there was some efficacy shown. Ravulizumab did produce more improvement in ADLs and also in QMG, another measure of myasthenia. And similar to eculizumab, the side effects were similar between the two groups without a major increase in signal. Headache, meningitis, vaccination required. These are the safety concerns. Now, that's complement inhibitors. I've gone through those. Fc receptor inhibitors work higher up in the immune system. So you have what happens with IgG molecules, these are antibodies that circulate in our system, is that they're taken up by the cells and they combine with these Fc receptors. And the Fc receptor is like a buffer. And the Fc receptor will take these antibodies back to the surface and release them. And so it prolongs the lifetime of antibody molecules. Those that are taken up by the Fc receptor are taken to a lysosome and they're broken down and degraded. Now, if you inhibit this, if you give an Fc receptor inhibitor that inhibits this combination of the Fc receptor with the antibodies can't bind to the Fc receptor inhibitor, and so they are taken to the lysosome and degraded. And this is a way that drops the abnormal antibodies, but also drops the healthy antibodies and all the antibodies by about 70%. Efgartigimod, that is approved in the US and up for approval elsewhere, was studied in the Dept trial. It's an IV treatment, and the improvement was based on those treated weekly for 4 weeks with this IV infusion, and 67% on drug improved compared to 30% almost on placebo. And the QMG, the other measure, again, there was much more improvement on the drug than not. And this shows the improvement if you're going by the degree of improvement you have to get. So if it's only 2 points, this is how many improved, and a lot of placebo did. But if you go up to 6 points, for example, the difference between those on placebo and drug is more profound, and similarly with another scale. And minimal symptom expression, which is what we want patients to achieve, was much greater on patients on drug than on placebo. And again, the safety profile was good, and similar side effects between the drug group and the placebo group. Rozanolixizumab also is an Fc receptor inhibitor, but given subcutaneously. This drug completed phase 3, and positive results of the phase 3 study were announced in December 2021, and patients were either on 10 milligrams or 7 milligrams per kilo or placebo, and they were treated here at 6 weekly treatments, and then they went into an observation period and could be retreated. And here is the ADLs in both drug groups dropped activities of daily living compared to patients who were on placebo. And the composite, Myasthenia Gravis composite, another measure, did the same. And, the quantitative Myasthenia Gravis score did the same. Both drug groups improved compared to the placebo arm. So the improvement at day 43 was highly statistically significant, and there were clinically meaningful drops, and IgG levels were decreased more than with placebo, and the abnormal antibody levels were also decreased. The safety events, again, there were more safety events with drug than without, but still comparable and easily treated. One of the concerns is headache. As I said, when you fool with the immune system, you often get headaches, and there were more headaches in the drug groups, but 45% in 7 milligrams and 37% in 10 and 19% in placebo. They were mild, and they were all managed with over-the-counter treatments such as acetaminophen. Zilucoplan is a complement inhibitor, and this is still in studies, and this shows you the study schema. And this just shows to week 12 that there is a drop in ADLs. So Again, this is just presented in May at the MGFA International Conference. These are early results showing the separation between placebo and drug. And the safety, again, comparable between the two arms. So these new drugs, the complement inhibitors and the Fc receptor inhibitors, appear to be fairly safe, and some of them are IV, and now there's more development of subcutaneous therapies. One exciting innovation is CART therapy, and the other is CART therapy. Here, this was from cancer medicine, where you take a patient's T cells, you harvest them, take them out of the body, modify them to recognize cancer cells, and then reinfuse them and hope that this modified T cell attacks the cancer cell. They are working on this for myasthenia, hoping you can attack the abnormal antibodies. And then this is for MuSK, where you give an autoantigen and let that is specific to the autoantibody, the MuSK. This is CART therapy. So these are exciting developments for the future. What I didn't talk about was bone marrow transplantation, because that is extremely rare, very aggressive, but has been reported to show long-lasting remissions in myasthenia gravis, but it's very not easy to get and not a regular therapy that we might use routinely yet. So myasthenia gravis treatment options have expanded greatly in the last few years. We have to individualize treatment to each patient. The novel immunotherapies are just completely changing our treatment approach and landscape. And what we need to do, probably with the CART therapies and others, is to get higher upstream to turn off the disease. If we could turn off the abnormal antibody production completely, that might be a cure, although I'm not sure. So thank you. I've come to the end of my presentation.
Great, thank you so much, Dr. Bril. And now over to Dr. Barnett-Tapia.
Okay, so I'm going to start sharing my screen.
Let me stop sharing.
Yeah, great, perfect, thank you.
Okay.
Okay,
There, stop.
let's see.
I stopped.
Can all see and hear me? So thank you very much for inviting me to be part of this webinar, and for MDC for funding my research that's directly related into patients. And I'll show you why we're doing this and some of the things we've been working on. So I'm going to talk a little bit about what have we learned from what the patients are telling us. So these are my disclosures in terms of my relationship with some commercial entities. So as Dr. Bril said, the advances in myasthenia gravis have been tremendous over the years. It's a different disease today than what it was having myasthenia gravis in the 1990s. So this is an old graph from a now a little bit old paper, but it shows how the natural history of myasthenia has changed. So here in the bottom, you have the year. You see, this is the early 1900s, where the mortality was close to 100%. This part of the name gravis means a severe disease. And part of this was that perhaps only the most severe patients were diagnosed, but also because there were no treatments in the 1900s. As we had advances with medicine and we developed tracheostomy, intubation, ability to have ventilators, neostigmine, which is the precursor to pyridostigmine, other medications, antibiotics, then thymectomy began to take hold in myasthenia in the late 1930s, improvements in ventilation, steroid use, plasma exchange, and so forth. You see that this curve of mortality has dropped, and now we're sitting a little below 10%. So the majority of the patients now have a way better prognosis, a good prognosis with myasthenia gravis. We also know that with current treatments, if you look at different data from different centers in the world, most patients improve. So the majority of the patients will get better with treatment. Roughly 5 to 10% of patients have what we call refractory myasthenia. Those are patients who are harder to treat with conventional treatments. However, despite these major advances and all we've come through, as Dr. Bril said earlier, most patients are not cured. So patients who achieve complete remission, where the disease is completely resolved without any medication, is quite low. It's about 10%. The majority of the patients who get better either have some residual symptoms and or need chronic medications. And what we're coming to learn more recently with some of the studies that we and other groups have been doing is that even when we think we're doing a good job and patients are better controlled, many of patients with myasthenia, even with good treatments, still have unacceptable symptom burden. They still have symptoms that affect their ability to do their daily life activities and have good quality of life. So they may be better, but they still have limitations because of the symptoms. One thing we were looking into something called patient acceptable symptom state. And a lot of research in the old days, a lot of the research was driven by what doctors and experts thought was relevant, but there's been a move in medicine towards getting more the patient's opinion and their own views of what's important to them. So this really simply means asking the patients if they are happy, if they are okay with their current disease status. So we ask a question that has been validated. It says, if you had to stay with the similar degree of symptoms of myasthenia for the foreseeable future, would you consider that acceptable? So it's not something very sophisticated, it's really asking patients. And it doesn't matter where you start, it's right now, are you happy where you are? And that's called patient acceptable symptom states, or PASS for short. So we have done this in different ways. This is a study we did a few years ago when patients in our clinic, we asked them this question, and over 120 patients with different degrees of severity. This is our question. And roughly almost 70% of patients were considered their status acceptable. If you think it the other way, about 30%, so almost a third of the patients reported that their current myasthenia status was not acceptable. They were dissatisfied with the disease status. That's, for patients who are receiving active treatments. What we found, not surprisingly, is that patients who were PASS or they said their status was acceptable, had lower disease severity, so had less scores in any measure of symptoms and fatigue and overall disease activity. But if you see in this plot here, there's some overlap. So some people who said, they were happy with their current disease state, most of them had lower scores, but some of them, despite having symptoms, considered their status satisfactory. And the other way around is also true. Some patients with that said no, they were not acceptable. Many of them had higher disease severity, but some were relatively well controlled. And this is where we have to remember that patients are more than just the disease. There's a lot of things that influence how the disease affects people's lives. And treatments are a big part of this because all our treatments have potential downsides, among other factors. And we have come a long way into now using this concept of seeing how the burden of disease in different cohorts. So for instance, this is a study, so to show this is not just us in Canada, this is a beautiful big study in a Swedish cohort where they were able to get a survey of roughly 40%, I think it was, or almost half of all the people with myasthenia gravis living in Sweden. So a very big study. And what they found, it was almost 40% of the patients, 4 in 10, had an unacceptable disease burden. So you see, came with an editorial saying that, are we there yet in terms of getting good outcomes for people with myasthenia? So 40% had over 3 points in this scale, which is the MG-ADL. So anyone from the 4 up are patients who have too many symptoms that most patients would say they're unacceptable. And you may say, oh, maybe it's just the Swedish. There's a big registry for the Myasthenia Gravis Foundation of America. They have over 2,000 patients registered. They've also seen that there's a big burden of symptoms, even though patients are treated. Some things we've seen, commonalities in different countries, in different cohorts, is that women with myasthenia tend to have more symptoms and lower quality of life. And we don't know if this is because the disease presents differently in women, or is this because perhaps doctors are not as aggressive in treating women? Remember, myasthenia, there's often a peak in women who are, of childbearing age. Perhaps that may drive some decisions. Could there be biases in treatment? We don't know, but we see that consistently, that women report lower quality of life and more symptoms. This is another study to show you that not only from the clinician us doing studies, but from the patients, we're finding where the gaps are into how we understand the burden of myasthenia gravis from the patient perspective. This is a study that was done through patients and analyzed by patients. If you have a chance to read it, it's actually a beautiful study that was led by Nancy Law, who was the CEO for the Myasthenia Gravis Foundation of America, and who sadly passed away recently. And this study interviewed over 100 patients trying to understand the impact of myasthenia gravis in their lives. And some of the things they found, which any patient hearing this will say will, I think, feel related, is things that often physicians don't think about. One is the effect of living with a disease that fluctuates and is unpredictable. So myasthenia causes fatigue and fatigability. So the muscles, as you know, get weaker as people with myasthenia use them longer. It's also unpredictable. Sometimes patients are doing really well and there's a flare-up, and sometimes patients change day to day. So patients reported in this study, and we see that in clinical practice all the time, that it's hard to plan your day when you don't know if you're going to feel strong or not in the afternoon or later in the day or tomorrow. And that unpredictability causes also reduced quality of life and anxiety. In the same thread, patients reported that they live in a constant state of adaptation, always making trade-offs of, what's important, what's not, and what do I do, how do I preserve my energy, or what things I do really want to do so that I'll put my effort into that. Many patients also felt that there's often what they call treatment inertia, meaning that their healthcare providers were not willing to change treatments when they've been stable for a long time, perhaps for fear of adverse events. So they felt many times they could be undertreated. And often they felt a sense of disconnect with the healthcare providers, like the things that were important for them versus the things that may be important for the healthcare providers were different. And all this led to mental health issues with anxiety, frustration, guilt, anger, loneliness, and depression. And within the same study, patients identified some unmet needs from their perspective. This is just a summary of many more things. But of course, everyone would like to cure MG, but they would value better long-term treatments and tolerability. So side effect profiles is important, have more treatment options for MG, more information. Patients want to hear more about new treatments, broad access. So many treatments, especially new treatments, tend to be expensive and hard to get. So accessibility is a problem. Better understanding from the healthcare providers on treatment goals, so better connection between what the patients and the physicians, better communication, use more technology to engage and educate people, and psychological support. So you see there's a major need despite all the advances that we've had into improving patient care. I'm not going to go through this. This is the way I kind of think in my head of all the treatment options for myasthenia when I teach for residents in neurology. But just to show what Dr. Bril was summarizing, there's many treatment options now and many more that are coming. This is not a comprehensive list. So yes, we do have treatment options for myasthenia gravis. And I always like to think, what would be a perfect drug? So if we had a drug that was 100% effective, meaning we give the drug and it treats everything, it's a cure. That also works in everyone. So it doesn't matter if you have a subgroup because you're a woman or male, young or old, it acts the same in everyone. Has absolutely no side effects and is affordable and easy to implement. We would have a perfect drug, and then we would treat and cure everyone, and we wouldn't need to have all these discussions. But this does not exist. And every single medical intervention, even if you take an over-the-counter medication, has potential adverse events. And there's always this trade-off between getting the symptoms under control versus the amount of side effects that an intervention may have. So what are some potential balancing act in myasthenia? So common symptoms of myasthenia are double vision, droopy eyelids, difficulty swallowing, chewing, speaking, reduced facial expression that physicians, we often don't think about it, but many patients find that very distressful, shortness of breath, weakness, restrictions in the abilities of daily living. On the other side, the treatments that we have for myasthenia have many potential problems, such as risk of infections, potential risk of cancer, diabetes, high blood pressure, cataracts, osteoporosis, et cetera, So there's always this trade-off into how aggressive you go with treatment and how much control patients need for their specific circumstances. So this is an example. This is just made up that how people make decisions. So perhaps a patient says, I've been offered this medication that might make my double vision better, give me more strength, less likely for me to come to hospital, get better control of my fatigue. It's only 1 pill a day and I'll be able to move better. However, I've been told that I'm very likely to gain weight. There's a risk of infections. I might have to monitor myself for cancer in the long run. I need to do periodic blood work. I may lose some hair, and it's expensive. And you can see how different people will make different decisions. And even though we're thinking from the patient perspective, physicians, we're also doing this. And sometimes, in the background, every time we see a patient, we try to think what's the best treatment for that patient. And we're always balancing act this. So every decision in life, but also specifically for medications, is this balance. And this is what we're trying to learn with our research, is understanding how people with myasthenia make treatment decisions. So we want to see how people with myasthenia, what things weigh more for people with myasthenia in terms of what symptoms are more bothersome, or if there are groups of people where some symptoms are more bothersome than others, what side effects of treatments are more concerning versus others. And we also want to compare that to physicians, because we know from other diseases that physicians and patients often see things in a different way. And we want to see where the differences are so we can help improve this communication and this shared decision making. So I'm not going to go into details in this, but we're doing this called a discrete choice experiment. So this is actually based on all the behavioral economists that say, if you want to know what someone really prefers, you need to force them to choose. So you can ask people to make lists of things. Yes, I like this, I don't like this. But when you're forcing someone to make a decision, that's when people show their true preferences. And this is what we're trying to learn, what people would do, what people would prefer. So the first bit of work we've done, we interview patients with myasthenia, and we also looked at the literature. And we were very focused to understanding symptoms that were bothersome, concerns about treatments, and treatment goals. Because remember, we're trying to answer a very specific question here with our preference experiment. And this should not surprise anyone, because it's what we've seen before in the literature. But patients reported all the symptoms that you're aware with myasthenia. Double vision always comes up as a symptom that patients find very, very bothersome. Even though, double vision is not a life-threatening symptom as compared to difficulty breathing, for instance, but double vision is very disabling. And in many studies, this has come up as something that patients are really bothered about. When we looked at adverse events of treatments, 90% of the adverse events were all related to prednisone. So patients really did not like the weight gain, potential mood swings, osteoporosis. Everything was almost related to prednisone, perhaps with the exception of diarrhea that is usually caused by a pyridostigmine. Patients, besides reporting individual adverse events, really felt that they had a concern about side effects from prednisone in general. They would like to be able to reduce the dose of prednisone or take less prednisone. The other treatment goal would be to ideally return to normal or having no symptoms, taking less pills, or if not possible to have absolutely no symptoms, at least have minimal symptoms. So you see there's a balance between better disease control, but also having less prednisone. And the majority of the patients in the study preferred taking a pill over infusions. So if they could choose, they said they would rather take a pill at home than having to go to the hospital or an infusion clinic to get an infusion. So with that, this is the things we're studying in this study. And you can see we can't put everything because there's just never enough space for us to ask all the questions we want, but these are the things we're going to be studying in this specific study that we're doing now. And as I should say, this is a work in progress. So we are creating hypothetical scenarios where patients and clinicians will have to choose. The things we're making varying or making different the scenarios are a new medication for myasthenia in someone who has symptoms, who is taking prednisone, and in whom the family, his physician, neurologist says you need a new treatment. So the new treatments, the options will have different efficacy in controlling double vision and droopy eyelids, difficulty efficacy in controlling breathing and swallowing and chewing, efficacy in improving your strength in the arms and legs, different risk of developing a severe infection. They will also have different efficacy in allowing you to go off prednisone. So you may, with this hypothetical treatment, patients can go off prednisone or have different degrees of level of prednisone. Medications can be administered by mouth, subcutaneous self-injection, or intravenous infusion. And we add cost here, not because we want patients to pay, but it allows us to make some calculations about what something's called willingness to pay. So it allows us to assign numbers to say, people would be willing to pay $100 more for, say, having to take 10 milligram less of prednisone per day. I'm just making that up. But it allows us to compare and see what things matter more for patients. And this is an example how our scenarios look. So patients will have 12 scenarios. So they have to make 12 decisions where, it says your doctor is offering you 2 treatment options for myasthenia, and treatment A and treatment B. And you can see here in this plot, in this little graph, that each treatment has different characteristics, right? One is better at controlling the eye symptoms than the other, but one is better at controlling the arm and leg symptoms than the other. One might result in no prednisone, the other will result in need for prednisone. They have different administration routes and different costs. So people are forced to choose. There's no perfect scenario here because, perfect scenarios don't give us an answer. We want people to choose with this imperfect scenarios, and that will help us assess what of these things matter the most. I suspect some of you are saying, oh, but how can you make a general, like an individual comment when preferences are by nature individual? Each patient is an individual, and that's very true. What we're looking is for overall patterns and comparison of overall weight compared doctors to patients. The other thing we can do is we can see if there's groups of people who behave in a similar way. So for instance, perhaps women of fertile age may have a different way for some things that older individuals or women versus men. So we can see there's patterns there. This is not meant to replace individual talks with your doctor. So in the real world, people would talk to their doctor. This is for us to know what's going on in the background. So I think I have a few minutes. I'll play a video. This is a summary of the video we did for the patient interview, for the physician questionnaire, and I hope the sound comes up.
Now, suppose you were treating a patient for their myasthenia, and they need to start a new non-steroidal medication for long-term management of the disease. You have 2 treatment options to choose from: treatment A and treatment B. Each option has different potential benefits and side effects. For each scenario, we want you to choose which treatment you would recommend if the treatments we described existed. There are no right or wrong answers to these questions. Remember that the 7 factors we want you to focus on are: 1. Efficacy in improving ocular symptoms. 2. Efficacy in improving eating, speaking, and breathing problems. 3. Efficacy in improving weakness in the arms, legs, and neck. 4. Ability to reduce the dose of prednisone. 5. Risk of severe infections. 6. Administration route. And 7. Out-of-pocket costs.
Okay. So we have another
Now,
video for the patients. I'm just going to skip ahead. We're in a loop. So what we're doing now is getting ready to launch this. The Myasthenia Gravis Foundation of America has kindly offered to send this out to their large registry, and we're looking to work with other patient groups to get more respondents. We need at least 250 people from patients, at least for this, and we're hoping to be able to launch the survey in the late summer. So we will hopefully get the information. What can we learn? So why are we doing this? This is an example for cancer. So you see that in this study that we're comparing patients and physicians' views about cancer treatments, and you can see that they found differences for some things. So patients valued some things less than physicians, and you can see what things were in terms of hierarchy more or less important. That's one of the things we want to learn here for myasthenia, and this has not been done for myasthenia, so we don't have this data. This is another example for cancer. Like in this study, we could say patients were willing to risk a 30% chance of a 40% chance of diarrhea if the medication would increase their survival by 18%. So we can get these findings with myasthenia, specifically for myasthenia symptoms and prednisone dose and all those things. And this is important for us as clinicians. I think we need to get more information about the way patients think about their disease and their treatments that we don't think about. What we're hoping is to improve communication and help people make shared decisions. But this is also used by things like decision makers. So oftentimes when new medications come down the pipeline and there's decisions about which medications to fund, these types of studies help payers. You know, if a medication is tackling something that patients have shown to be valuable for them in this type of study, that's something that's seen as favorable. It helps pharmaceutical companies to understand what areas they should be focusing, perhaps developing medications of a specific route or with fewer side effects. And we're seeing if this can help us in clinical trials. So I think that's my last slide. I think there's time for some questions, and I just want to help everyone to help us, MGNet and Muscular Dystrophy Canada specifically, because they're funding our work, and I'm really grateful that they're interested in our patient-centered research, and the MGFA who's really helping us launch this.
Thank you both so much for those wonderful presentations. And it's really exciting to see all the work that's being done and all the new treatments. So that is very exciting for us to see. We do have some questions in the chat. So our first question is, what information is needed for the Rituxan application? My doctor documented that I had failed all therapies and was MuSK positive, and application was denied.
I'll answer that. I'm quite surprised. This varies from province to province because the health ministry in each province determines whether they will fund it. MuSK particularly does respond to rituximab. I know in Ontario, you can get rituximab for MuSK patients fairly readily. It's the acetylcholine receptor positive patients that have a lot more difficulty. So I'm not sure where the questioner is living, but different provinces have different boards deciding this. And it's a really, it's one of my bugbears because I would like, 35% could respond even if they have acetylcholine receptor antibodies, and it's really difficult to get rituximab for that proportion of patients. And then we have fellows from India now who tell me that they can get rituximab for a nominal cost in India. And I know that in Scandinavia, rituximab is not very expensive. So I'm not sure why it is so expensive here that keeps it barred from use, because I have no insight into that whole process. But one of my patients said, do you think I should take rituximab? Because if so, I'll go somewhere and get it. There goes to another country because they can get it at a cheaper price.
Yeah.
So the respondent, the inquiry was based in Ontario.
Huh.
And so that surprises me because I haven't had that same thing. It makes me wonder if the application, what was said in the application exactly, because usually in Ontario, we don't have that trouble.
Yeah, I would say oftentimes you can discuss with the doctor to reapply. And sometimes what I've done in my patients is, besides the application, I send a letter, and often I add papers that support the use of the medication, for myasthenia. And so sometimes if they send that extra information, that might help.
Great, thank you so much for that. And so our next question is in French. This person has myasthenia gravis, and she was diagnosed in January. She started treatments back then in January, and she's still not feeling well. She's not able to live a normal life, and she's wondering how long will it take before she starts to feel the results of her treatment. And she is 28 years old. Sorry, 33 years old.
And that is one of our major issues in myasthenia. Some of the standard treatments that are available now take up to a year to work, and you start the treatment, you're waiting that long. sometimes we do bridging therapy with IVIG or sub-QIG to bridge that time when the immune suppressant isn't working. Prednisone usually works faster if you use enough of it. You know, 33-year-old woman may or may not want to be on prednisone. So it depends on what she's being treated with. It depends on the severity of her disease and how she's responding to the treatments and the doses being used and things like this. So myasthenia tends to be at its maximum severity during the first 2 years. When we look at our patients and look how long it takes for them to get to a pass yes in our center, it was something like 25 months, 2 years, right? Which is sad, right? But it's not that they didn't improve during that time. It's that they improved to a state that they found acceptable during that time. And, you know, at a young age, she may need thymectomy, so you have to measure her, you know, manage her before, then she has the surgery, then after. So these are some of the considerations. And of course, you know, that's just general because certainly we don't know her and, you know, personally.
Yeah, I see that she's added that she's on prednisone, azathioprine, and she just had a thymectomy last week. So thymectomy is not immediate. The effect of thymectomy takes, it's the long run, not the short term. But most patients with this treatments will improve and will slowly start to show improvements. But yeah, the hope for new treatment is hopefully to get treatments that also have fewer side effects, but also work faster.
Great. So then based on what you're saying, it sounds like it's still really early. So if she started treatment in January and we're in June, that's not exactly atypical, like to not see.
No, but you know, you would have thought maybe the prednisone should have produced some more improvement. But you know, she's saying she can't live a normal life, right?
Live a normal
right?
Right.
So
Yes.
that's the issue that we've been talking about, that even with treatments that we have now, there are patients who 30% who don't think they're living a normal life or an acceptable life. And so that's why we need these new treatments. You know, we really do.
And so she's saying that she was on prednisone
Azathioprine.
Azathioprine, yeah.
Thank you for correcting me. And yes, thymectomy just last week.
Yeah. So yeah, I would say still early, and we would expect her to slowly get better.
Yeah, great. Thank you so much. You know, we've had some inquiries over the last few weeks from people with myasthenia gravis who've had trouble finding neurologists who can actually support them and, you know, be able. And I'm wondering if you have any thoughts or advice on how they can navigate that challenge. So they have a neurologist who doesn't know quite how to refer them and give them a plan.
Well, you know, we see a lot of myasthenia gravis patients, and yes, we'd be happy to accept any referrals. And if the neurologist is a little hesitant, maybe through their family doctor, because we do follow quite a few patients in our center with myasthenia gravis, because there is a necessity for close monitoring and follow-up and modification and, you know, access to some of the new clinical trials, because sometimes, as you saw, there's extension studies that allow you access to the new treatments even after the study's done. So I think there's centers that have more expertise with myasthenia, and maybe you want to get to one of them. I mean, I think that's just a rational approach. And most neurologists are happy, though most community neurologists would be happy to have that burden shared.
I was going to say it depends on the province, but most big provinces will have some neurologists with a special interest in myasthenia. So, you know, it's sometimes a little bit of digging, but most, you know, in Quebec, there's neuromuscular groups that take care of myasthenia, Alberta, BC. So I think perhaps not not specialize in some of the more rural areas. That's always sometimes one of the issues, but most big urban centers will have a neuromuscular group or someone who has like a more interest in myasthenia.
Great. Well, we have hit 5 o'clock, everyone, and I wanted to thank our panelists today for sharing your expertise with us. And like I said earlier, it's really exciting to hear about the treatments and your interest in patient preferences for treatment. So thank you so much for sharing this incredible information. And those of you who may not have had a chance to ask questions, you can reach us at research@muscle.ca if you have any other questions after our talk today. Again, a special thank you for our panelists, and we really appreciate your time today.
Thank you very much for having me.
Thank you.
Thank you.
All the
for
best,
inviting
everybody.
us.
Bye. Have a
Take
great day.
care.
Bye. Bye.